The carotid artery is the superhighway for oxygen headed straight to your brain. It handles the vast majority of the blood flow that your mind needs to function every single second. If this vessel suddenly tears open, the condition is known as carotid blowout syndrome. Usually, this catastrophic failure happens because the artery wall has been heavily degraded over time by invasive neck cancers or intense radiation therapy. But recently, an 89-year-old woman arrived at a hospital with sudden, painless swelling on the right side of her neck. She had no history of neck cancer, no prior radiation. She had none of the typical clinical red flags. She was experiencing a purely spontaneous carotid rupture. These events are so exceptionally rare that doctors can only theorize their true origin. Without underlying diseases, the prevailing theory is that they are caused by repetitive, completely unnoticed minor trauma to the neck over a long period. On this CT scan, notice the massive pseudoaneurysm pooling outside the vertical artery. Instead of flowing to the brain, blood actively leaks from a tear in the anterior wall, creating a high-pressure pocket threatening to compress her airway. Because a spontaneous rupture completely bypasses all standard warning signs, a predictable, well-mapped vascular network is instantly turned into a hidden, lethal emergency. The traditional surgical response to an arterial leak is straightforward. Open the neck, find the ruptured pipe, and physically tie or clamp it off to stop the bleeding. But the human brain relies on a backup circulation network called the circle of Willis to maintain blood pressure if a primary route is blocked. In elderly patients, this backup system is often inadequate. If surgeons clamp the main carotid artery to stop the bleeding, and the backup network can't compensate, the interconnected upper cerebral network is immediately starved of oxygen. Because of this biological vulnerability, taking the open surgery approach to tie off the vessel carries up to a 60% risk of inducing a severe stroke in the patient. The medical team had to solve a lethal paradox. They needed to completely stop a catastrophic hemorrhage without ever turning off the local blood supply to her brain. They opted for an endovascular approach. Instead of cutting into the neck, surgeons thread a flexible wire from the femoral artery in the patient's leg, navigating it all the way up into the neck to reach the blowout from the inside. This angiogram shows the active internal bleeding from the surgical team's perspective. You can clearly see the dark, contrast-filled pseudoaneurysm ballooning out laterally from the main arterial line. The surgeons initially deployed a standard bare metal stent, but it failed to fully seal the microscopic tears. By the next day, the patient's oxygen levels dropped as the expanding hematoma began to crush her respiratory space. She was rushed back into the operating room for a definitive emergency solution. This time, they needed specialized covered stents. Unlike a bare metal mesh, a covered stent acts as a newly paved, impenetrable tunnel. It physically bridges the torn section of the vessel, blocking fluid from escaping outward while still allowing normal blood flow to pass vertically to the brain. Looking at this post-operative scan, we can verify the secure catheter placement and see that the previously ballooned mass is now completely excluded from the main circulation. By using covered stents, doctors are able to perform precise structural vessel reconstruction entirely from within a hostile biological environment. Fixing the pipe is only the first hurdle. To survive, the patient must navigate a highly critical 48-hour post-operative surveillance window to monitor her airway stability and ensure the vessel wall holds. At the same time, doctors face a complex pharmaceutical challenge, administering dual antiplatelet therapy, or DAPT, to an 89-year-old with pre-existing conditions. DAPT is a delicate biochemical balancing act. The patient's blood must be thin enough to prevent the new artificial stent from clotting, but not so thin that it triggers another deadly internal hemorrhage. There are currently no standardized evidence-based guidelines for managing this specific therapy in neurologically fragile or elderly demographics. Clinicians must carefully navigate the dosage entirely based on individual risk. Ultimately, surviving a spontaneous blowout requires state-of-the-art internal hardware, matched with perfectly calibrated, highly individualized post-operative chemical management. As medical imaging and tools improve, minimally invasive endovascular technology is offering much safer, highly effective alternatives to traditional open surgery for unpredictable, high-risk vascular emergencies. If you found this case breakdown helpful, please leave a like and subscribe to the channel. Let us know in the comments what medical mysteries or procedures you'd like us to cover next. This video was brought to you by Synestex Systems LLC, founded by Shane Persinger.